I'm a paediatrician in Kalgoorlie, so I see a lot of children that need to be referred to genetic services, and so I start the initial investigation and then refer them on to genetic services. But I also, with Annette, work with the genetic services team to provide a better service and a better understanding of the Aboriginal patients and for the Aboriginal patients. And what we've done in the Goldfields is actually facilitated the genetic team, and particularly the geneticist, actually meeting Aboriginal people, getting known in the community, and Annette particularly vouches for him that he's a friend, he's a good person, and it's safe and a good thing to go and see him. And that's kind of an informal thing that's happened.
Yeah, and even explaining the visit that we do when we come to the community, and explaining what we are there for and what we're going to do, and encouraging them, because later on in life it's their next generation to know, make sure they're all good.
Really for all medical encounters, but particularly where it's something sensitive like this, for Aboriginal people from our region, relationship is critical. And so knowing that the doctor can be trusted, and preferably actually knowing him or his team, is critical to confidence in the service and in the medical encounter.
I think the first thing we can do is break down the barriers to referring Aboriginal and Torres Strait Islander people to genetic health services, which involved increasing awareness at both primary care and specialist services of the kinds of conditions that people should be referred to.
Public health promotion is a very important part of any sort of a service, and should be a part of any services, getting out there and speaking with people about what they offer, also what are the important messages with respect to health. And that doesn't only mean at our tertiary level, so in terms of our hospitals and health services that are providing inpatient type of facilities. It also means at the front line, which is our primary health sector. So that, for instance, is our general practice sector, and then generally widely, more of a public promotion sort of a campaign, letting people know widely what is precision medicine, what is genetic health, what is genetic testing, what is genetic counselling, I think what's most important is having a conversation, if you're a clinician, or if you're a support person, or if you're a family member or primary health care provider, with the person about the potential benefits and the potential risks. Empowering that person, who may also be your patient, your colleague, your friend, your family member, to actually make an informed decision. You as a practitioner are going to be the conduit between this person and the service to whom you're referring. So you need to be informed, number one, about what genetic services are, about what testing might be available through that service, so that you can start the conversation. And then, based on that conversation and the person's informed decision, you can support that person to access the service.
We need to have GPs trained a lot more. We need representatives to go to every clinic to make sure that there are the right information and right referral pathways for our patients. We've got Aboriginal liaison officers in most hospitals. A lot of them have been there for many years. Those doctors should know their names on a first name basis.
Secondly, we can make it easier for Aboriginal and Torres Strait Islander people to attend appointments at clinical genetic services by providing better support in the lead up to attending, and providing better support as people receive clinical genetic services and when they return back to their usual sources of care.
In the communities, there is no services like that. You have to fly someone out. In a way, it's scary for people when they come into Darwin and not seeing, not a familiar face. It might be, and too much information is given.
We're trying to look at different models of service provision to make it easier for Aboriginal people to access our services, and that might be actually changing the model of care where, a big doctor goes to a hospital and sits in a room and expects a family to come 8 hours to see them. Actually, it may well be better for a counsellor or an Aboriginal health worker to go to the communities to provide that information to the families in their own community. And then we can be used as the specialists only if further information needs to be given. So that sort of devolving the care to the communities, again, is empowering people, because it's much easier if a doctor can come and see you in your own house rather than making an 8-hour bus trip.
Yeah, I've been an Aboriginal Hospital Liaison Officer for 15 years now at Burke Hospital, and I think that is a very important role. We would like a doctor and other genetic counsellors to come to Dubbo and speak to us about the genetic services and give us that education for the Aboriginal health workers and other health people. We can go and do it out in the community, not in a hospital setting or health setting, but go and do it where they feel that maybe just sitting on the riverbank, or maybe just out in the park, or talking about these genetics with people. You may find that it could be upsetting, or people are happy to find out more about it, or you don't know. And I think we need to do it on their terms, not our terms as health professionals.
One barrier that I hadn't really appreciated is people considering a cost. So from our perspective, we're a clinical service that's through Queensland Health, so we're a public health service. So if we consider a test to be clinically important, we fund the testing. And I think some people think that because genetic testing is sort of advanced and complex, that there must be a significant cost to them, and so we'd like to reassure that there isn't a cost. We liaise with the local health services to ensure that patients can get transport. Some of our patients in Indigenous communities have a long distance to come, and it's important that they get support for the transport. So we do have a patient transport scheme, and it's important to liaise with them about getting there. Additionally, we use a lot of telehealth in Queensland. Many Aboriginal patients might live in remote communities or difficult, and even to get to the local hospital is quite a distance. So we do a lot of telehealth whereby we use direct patient, and in that setting there's often a clinician, say a nurse, with the patient at the other end, or family members can come as well. So we do what we can to actually enable people living in rural and remote communities to access the service.
If you live outside of Kalgoorlie where the clinic is held, if you come from the north, there's only a bus once a week. So you might be away from home for 2 weeks, and there is PATS to help cover that, but that will only pay for one parent and the child, and you have to stay in a hostel, and it doesn't cover everything. And so it can be really difficult for families to come in the first place, and really, anyway, the whole family should be involved in the consultation, not just the one parent and child. You at least need 2 parents and probably some grandparents as well. That's where cost becomes a major problem.
Family is really important. Make sure you involve all your family and all that support that you have there. Even close friends that you trust, you can talk to someone that you very well.
If we want to fix what's going on here in Australia with Aboriginal and Torres Strait Islander health, we need to offer more. We need to be out there more.
Finally, there is an element of clinical genetics that is a little bit different from other areas of health equity, and that is genes are not evenly distributed throughout the world. And the rarer condition is, the less likely it is that it will be found in all of the world's populations. And that's particularly true of populations like Aboriginal and Torres Strait Islander people who have been geographically isolated for many years from other populations in the world. So really at the moment, about 78% of the data in the world on genomics is from Europeans. There's very little on other populations. So there is a benefit by making the people who are involved in our clinical genetic services more diverse. There's a benefit to everybody. It will increase medical discoveries and in turn medical treatments. Not only that, for Aboriginal and Torres Strait Islander people, we have a particular obligation because they don't exist anywhere else in the world. If we're not inclusive of their needs in Australia, that won't happen anywhere else, and any learnings we might make will be lost.
In Australia, Aboriginal people experience racism and exclusion all day, every day, and so they come to expect that will be normal. Doctors tend to hide behind a professional facade, and we're taught to do that actually, so we think it's normal. But those two things create an enormous divide between the patients and the clinicians. And if you can bridge that divide by just getting to know each other and being human, the whole thing becomes so much better for everyone, the clinicians as well as the patients. And so that's something that's particularly important for Aboriginal people because of the cultural and spiritual aspects of relationship and healing. There can be no healing, there can be no therapeutic relationship without personal relationship.